This is based upon OASIS data as of 2009, so that's where we get our numbers from. And the number of low birth weight babies at that point in time was about 6,300 in the metropolitan Atlanta. Through our network process, we identified this as a community goal, as well as what you probably don't hear a lot of is the reduction of the racial disparity that exists with African American women in comparison to other racial and ethnic groups. African American women deliver in terms of low birth weight babies about twice the rate. And so we had that as a secondary community goal to support the number, or the reduction rather, of the number of low birth weight babies. And that it's critical for us just because in Georgia the leading cause for infant death really has to do with a baby being either born too early or too small. So as an indicator for us, we use birth weight. So part of our key strategies, or the umbrella in which our strategies are developed, it falls primarily under three areas. Today we're going to be discussing our home visitation strategy, and that basically falls under our health behaviors kind of bucket. And that bucket really is to address the health behaviors of women within the context of their families and their communities. We know in Georgia that Georgia is really one of the states in terms of that has the highest number of low birth weight babies, and we see that as a reflection in our metropolitan Atlanta area. So our strategy description for our home visitation really is what we're looking for is an evidence-based, a voluntary, home-based program that primarily matches expectant parents with trained professionals. The whole idea is to help support mom throughout her pregnancy as an early intervention to make sure that her knowledge in terms of her health behaviors, prenatal care, the things that would impact her pregnancy adversely are addressed. And this is to really reduce the risk of delivering a low birth weight baby. So what we have done is come up with a few questions, key questions that some of the programs had asked, and we wanted to put them up today to address them because we felt other organizations may have those same questions, particularly for the LOI process and to move forward. The three questions begin with what current evidence-based home visitation program are you currently utilizing? We listed in the strategy guidance letters a few examples of home visitor models that address the perinatal period. What you'll see is the Healthy Families Georgia model, the Nurse Family Partnership, Parents as Teachers, and a Healthy Star as examples of evidence-based models. We ask that you utilize an evidence-based model simply because it is really shown to improve outcomes, particularly around birth. They also incorporate key and critical components that address more than just the medical piece and have a holistic approach. What the network did was we wanted to have strategies that would address what we call the social determinants of health, or simply put, things that would impact our health outside of the medical piece. So where we live, the level of maternal stress that occurs, where we work, our finances, all the things that kind of make up how healthy we are. We wanted to have a strategy that was flexible enough to incorporate other pieces outside or in addition to the medical care component. And so we listed those there as context for you to be able to understand what types of programs that we're looking for. Our second question was we wanted programs to be able to provide evidence on how their model aligns with our community target. Again, our community target is really addressing low birth weight, and that's just an indicator of the health of the child. And so what that means is that we want programs to be able or have the capacity to collect data, whether it's through an MOU process or some substantiated formal record that we can collect data on birth weight. We want to make sure within the program components that there are essential pieces that address things such as maternal stress or depression, health education, And what we've learned from looking at home from evidence-based programs, that those programs tend to address things outside of the medical piece. And so we want to make sure that programs are able or have the capacity to show evidence that there is alignment to being able to collect and address birth weight, but also maternal health. Our third strategy is describing the target population. We ask that programs describe the target population for the program and how they intend to reach that population and what outreach efforts will be put in place. What we've learned through research, and we'll also address it in this webinar, is through the data and the research, we've learned about particular populations that are most impacted by adverse birth outcomes. What I talked about before in terms of our secondary goal was to address the disparity between African American women and those compared to other races. I wanted to be clear that this strategy is not a teen pregnancy strategy, meaning that teen pregnancy is not a priority population for this particular strategy. I did want to highlight that to make sure that people understood that. But they have to make sure that they describe how they reach their target population and what the outreach efforts are going to look like. So a few questions came up around, and I'll read them off and then I'll provide some context for them. If I am in a current partnership under the Babies Born Healthy, whether network or in any type of partnership, can I apply in the investment process? Well, to address that question, being in a partnership with the Babies Born Healthy network or other work that we're doing does not preclude any organization from applying through the investment process. We welcome organizations actually that are partnering because they are closely tied to the network and they have a good understanding of the strategies that we are implementing. A second question that organizations may ask is this strategy similar to the family engagement strategy, and can I apply under the strategy, this particular home visitation strategy and the family parent engagement strategy? So the family and parent engagement strategy that sits in our education portfolio has some similarities, but is a very different strategy. The family parent engagement strategy is primarily focused on the education, leadership, and family support, and the expected outcomes tend to be associated with improved relationships among the parent, child, school system, and providers, whether it be family or center-based. That is very different from the home visitation strategy. Although the home visitation strategy may incorporate some of those key components, the home visitation strategy is really a health strategy, and it's focused on the well-being of mom with the expectation and evidence that she delivers a healthy baby. So programs can apply for both strategies as long as they follow the guidance that has been provided for each of the strategies. We always look to make sure that there is transparency and that there is a clear distinction between the work and the implementation of both strategies if an organization should choose to apply for both strategies. Our third strategy, which I addressed a bit earlier, is this funding for teen pregnancy? And the reason why I brought it up again is because we do get a lot of questions. It's not that we don't fully, like if there are some teens in the program that we don't fund, of course we do, but this strategy is not a focus primarily on teen pregnancy. The Babies Born Healthy Network, through a literature and data review, determined that this strategy would not prioritize or target teens specifically. Although the incidence of low birth weight is higher in teens and women over 40, births to these age groups do not account for the rise in incidence of low birth weight. Together, these two age groups account for less than 10% of the overall increase in low birth weight, and that's been since 2000. Low birth weight is increasing in groups over 18 and under 40. And so thus our home visitation strategy looks to target women within that age group. In terms of process reminders, our letter of intent deadline, again, is January 24th at 5 p.m., which is pretty much close of business. All letters of intent must be submitted via the online database manager, otherwise affectionately known as ODM. Notifications back will be after February 4th. and we welcome any feedback that anyone has or any questions. At this time, I'm going to pause and see if there are any questions that individuals on the line may have. Again, I'm going to ask and pause for a moment to see if anyone on the line has any questions. Yes. Okay, we have one question. One moment. Hi, Audra. I see that you have a question. You can go ahead and ask.
Hi, Kim?
Yes.
Can you hear me?
Yes, I can hear you.
Thank you. My question was, is there an entry eligibility requirement for the mothers? Do they have to be pregnant, or could they have just had a child, or what are the requirements for entry into the program as a grantee?
Yes, so this strategy is focused on pregnant women because if you notice in the strategy guidance letter, for our long-term indicator, the data that we're collecting is around birth weight. So women must be pregnant and be served through the home visitor program. Now each model, and so instead of me saying, 13-week gestation within the first trimester, a lot of times the visitor model will determine at what perinatal period the woman will get picked up, but she will indeed have to be pregnant. Does that answer your question, Audra?
Yes. Yes, okay. It does. Thank you so much.
Okay.
We do have another question. I apologize.
You're fine. Okay.
Is there a referral service or any intake being done by United Way or selected providers?
Can you, what do you mean? I'm not sure.
It's assigned to assist in finding women who are pregnant?
No, but there are models. I mean, we're working right now in Clayton County with Clayton County Public Health, and they've set up a referral, and we have kind of that infrastructure laid out, so we can always provide that type of support in terms of what different models are being used in terms of a referral system. But we are not finding pregnant women for your programs. That would be something that you would need to do. What we look for is partnerships. Ideally, it would be great if a nonprofit would partner with the OB office to create a screening system, which could be something really simple, if to set up a particular criteria and then have those women referred to your office for further support if there is a high-risk pregnancy. You can also have a partnership developed with a public health site. So anybody that serves pregnant women, particularly in the medical field, which you'll most likely find within the health department or a private OB or even a hospital system, to be able to make those referrals to your program. And if you're receiving funding, those services should be at no cost to the mom. It should be a win-win if that is something that can be set up. Because that's pretty much what we're looking for. We're looking for non-traditional partnerships with medical providers and nonprofits to be able to serve women outside of the medical and in conjunction with. So making sure that she makes all of her OBs, all of her prenatal visits, making sure that there is a nutrition program. But all of those types of things, all of those components will be found in a visitor model, so it'll incorporate all those pieces. What you'll probably have to make sure is set up and is strong is really the partnerships in the community to make it all work.
Wonderful. Thank you.
You're welcome. Are there any other questions? So if you find that you have questions after the, I'm sorry. Yeah.
Hey, this is Natasha from Atlanta Healthy Star. How are you?
I'm good. How are you?
Good. I have a quick question, and not sure if I missed this. Is there a required number as to how many pregnant women an applicant organization has to serve for the project?
No, we didn't really set up a minimum. It's
Okay.
just your ability to how many your capacity to serve, basically. We wouldn't really dictate that because it really just depends on what a program can actually do.
Sounds good. Thank you.
You're welcome. I have one more question. Hold on one second. So there was a question asking, are there other reporting requirements outside of the standard 6-month and annual reporting period? And there is not any other reporting requirements outside of what you would normally put and go through our ODM system, and that's at a 6-month interval and at the annual interval. I will say, though, that and some of you may have, if you are already receiving funding through other sources through United Way, we do program. There is a process which we call program monitoring and support. So there are visits to make sure that you have what you need. But in terms of reporting requirements, there are none outside of the 6 and annual period. 6 months and 12 months. What I was going to say before was if you feel like there are questions that you may have, some of you know me, you can email me or you can email grantee@unitedwayatlanta.org. And in the subject line, just put home visitation for babies born healthy question, and they'll be directed to me. Okay. I thank everyone that joined the call this afternoon. Will be available online. Oh, I'm sorry. The webinar will be available online to access. We're recording this call, so you'll be able to access at a later date. So thank you very much. I hope you guys have a wonderful weekend, and I will talk to you soon.
The leader has disconnected. The conference will be terminated in 2 minutes.